Hi everyone, I'm Tanzila Potia and today I'm going to talk about the McKenzie method, mechanical diagnosis and therapy. The McKenzie method of mechanical diagnosis and therapy is an internationally researched and acclaimed system of assessment and management for spinal and extremity musculoskeletal disorders developed by New Zealand physiotherapist Robin McKenzie in the 1950s. It has been widely used all over the world for more than 60 years. Clinicians trained in the MDT system are able to assess and classify all complaints of the musculoskeletal system. That means that if a problem is arising from the spine, extremity joints, muscles or tendons, then an MDT evaluation is appropriate. An MDT clinician will be able to identify if it is indicated, what management strategy is best, and outline a predicted recovery pathway. One of the key features of this method is the initial assessment. It is a safe and reliable format to reach an accurate classification and only then develop the appropriate management plan, taking into account all the various factors that can influence the patient's experience of pain. The benefits of MDT. Firstly, it has a reliable assessment. We all know that to be effective, any treatment system must be based upon a sound assessment and an accurate diagnosis or classification. A recent study done by Heather Abadi et al. 2014 supports the reliability of the McKenzie system. Studies done by May and Rosedale 2012, May and Aina 2012 provide data on the prevalence rates and demonstrate the comprehensiveness of the system. Further, a study done by Appledon et al. 2016 supports the validity of the diagnostic process. Edmund et al. 2014 support that the McKenzie evaluation process makes it possible to predict patient prognosis mostly within 1 to 2 consultations. So the other benefit of MDT is that we can have an early prognosis for our patients. The emphasis on self-treatment empowers the patient and helps foster a strong sense of independence. Research done by Vadat et al. 2014 demonstrates that patients who are empowered through participation in their own care acquire the skills, knowledge and confidence that result in beneficial outcomes. Using the MDT strategies has been shown to be able to give better outcomes to the patients. This includes reduced surgery rates as per Rasmussen et al. 2005. It also helps to avoid surgical interventions, lead to better outcomes than therapy that is focused on spinal manipulation or general exercises. It's also known to be cost-effective. With reference to prevention of recurrence, patients who have been educated on self-management are able to initiate treatment at the first sign of recurrence. Cardinal features of MDT. The first most important feature is the classification of subgroups. Secondly, we focus on centralization of symptoms. The treatment perspective that focuses on self-treatment and patient education, as shown by Vadat et al. 2014, is another important feature of the MDT system, as well as progression of forces. So today we are going to talk about patients that come to us with neck pain. A clinical guideline for us is that any patients that have mechanical neck pain or cervical radiculopathy are suitable for mechanical evaluation through the McKenzie system. However, patients that have serious spinal pathologies would be required to get a referral for specialist opinion. Certain contraindications that we must keep in mind before we follow the McKenzie system are patients that may have a spinal cord lesion, patients that present secondary with fractures. The fractures could be due to a motor vehicle accident, it could be due to a fall, it could be due to diving in shallow water, as well as patients that have ligamentous instability secondary to conditions like rheumatoid arthritis. Patients with tumors, spinal infection and vertebrobasilar insufficiency are also contraindicated from the McKenzie system. The subgroups of MDT. There are 4 main subgroups that we talk about. First comes the derangement subgroup. This is the commonest and the largest group of patients that present to the clinic. Internal derangement causes a disturbance in the normal resting position of the affected joint surfaces. Internal displacement of articular tissue of whatever origin will cause pain to remain constant until such time as the displacement is reduced. Internal displacement of articular tissue obstructs movement. One of the characteristics of the derangement syndrome are that the patients have a varied clinical presentation which may also change from day to day. They may present with worsening of or peripheralization of symptoms in response to certain movements. The second category or subgroup of MDT is dysfunction. Pain from the dysfunction syndrome is caused by mechanical deformation of structurally impaired soft tissues. Previous trauma, inflammatory or degenerative processes may cause contraction, scarring, adherence, adaptive shortening that causes pain when the abnormal tissue is loaded. Intermittent pain produced only when loading structurally impaired tissues is a classification of dysfunction. The third syndrome that we come across are the postural syndrome. Pain from the postural syndrome is caused by mechanical deformation of soft tissues or vascular insufficiency arising from prolonged postural or positional stresses. Time is an important causative factor. Intermittent pain brought on only by prolonged static loading of normal tissues is a factor in postural syndrome. The fourth subgroup of MDT is the others. They are patients that are mechanically inconclusive, patients with chronic pain state, whiplash-associated disorders, stenosis, and trauma. Coming to the progression of forces. One of the features of the McKenzie system is that the forces used are initially patient-generated. Moving on to patient overpressure, therapist overpressure, mobilization, and then manipulation. There is a strong focus on the independence of the patient within the McKenzie system. Therapist-generated forces are only used when the reduction of symptoms is not brought upon by the patient-generated forces. The management principles used for derangement syndrome. The key to correct management is the identification of the appropriate loading strategy which will reduce the derangement and improve the signs and symptoms. The extension principle is the most common directional preference displayed by cervical derangements, with well over 60% responding to these forces as per McKenzie 1990. Whether the patient has symmetrical, asymmetrical or unilateral symptoms in the neck, arm or forearm, it is still necessary in most cases to explore sagittal plane movements of flexion and extension first. So now we're going to talk about some practical procedures. The first most important technique that we have to do in McKenzie is posture correction. We're now going to show you a video which involves teaching the patient how to do a slouch overcorrect and the correct use of a lumbar roll in the McKenzie program.
This is the original McKenzie lumbar roll. It is used throughout the world to help support good sitting posture. Ella will now be practicing 10 to 15 repetitions of the slouch overcorrect. She's moving from slouch posture to all the way the extreme of the good posture, slouch again, and all the way into the correct. And let's assume she did 10 to 15 repetitions and she needs to maintain the small of the back accentuated and supported. In order for her to achieve that, she will glide her buttock all the way to the end of the chair and bend a little forward and now lean against the lumbar roll. The lumbar roll sits tightly and snugly against your lower back. It maintains a lordotic curvature in its correct alignment and allows you to sit with good posture for a prolonged period of time.
The patient is asked to sit upright using a lumbar roll for proper posture. Patient is asked to keep fingers of one hand as a check in front of his chin. Patient is asked to move his head as far as possible, keeping the head facing forward and horizontal during the movement. The movement should be made to the max end range of retraction. The patient may relax back to the starting position where fingers are placed. The same movement must be repeated rhythmically 5 to 10 times. Encourage patient to move further than before, going into the end range of retraction. Retraction and sitting with patient overpressure. Once patient is proficient in retraction, overpressure can be applied by the patient using the fingertips of one or both hands against the mandible. It is important to avoid flexing the cervical spine when the overpressure is applied. The next technique is retraction and sitting with clinician overpressure. This technique is used only when patient-generated forces in retraction are not resolving a posterior derangement and there is insufficient range of motion to introduce cervical extension. The patient is sitting upright in the correct-seated posture. The therapist places the heel of the hand on the center over the spinous process. The therapist keeps the forearms parallel. While the patient is instructed to actively retract their neck, the therapist will apply gentle overpressure with both hands simultaneously. Let the patient relax and the retraction comes to the neutral position. Retraction and supine with pillow support. Patient should lie supine on the treatment table. This technique is used in very acute cases during initial treatment sessions when the force alternative of unloaded forces is required. Patient is instructed to retract the head into the pillow, hold for a second or two and then relax. Retraction and prone. Patient lies prone, leaning on the elbows so as to raise the upper trunk. Patient is going to look down so the neck is in neutral position. Patient retracts the head and neck in the same manner required when the exercise is performed in sitting. After repeating the movements, patient rests the chin on the clasped hands. Patient can also apply overpressure at the end range of retraction by using fingertips of both hands on the mandible. The prone position has the advantage of producing a marked retraction force in the upper thoracic segments, which is often difficult to achieve in the sitting or supine position. Retraction and extension. This can be performed in sitting, supine or prone. In the sitting position, patient is instructed to do retraction as far as possible and then instructed to continue to tilt the head backwards as if to look skyward. After a second, the patient should bring the head back to neutral position. This is the second progression of force used for reduction. Retraction and extension with rotation and sitting. An increase in range of extension can be achieved by adding a rotary component while the neck is extended. A minimal rotary adjustment of the head 5 or 6 times such that the nose moves only half an inch to either side of the midline. During this process, patient is urged to move further into extension to gain maximum end range. The rotation is the equivalent of an overpressure. Certain useful links, the MDT clinical definitions, the common misconceptions of McKenzie, and a research and resources form that has all the assessment forms for the various McKenzie body parts is present in. Moving on to the references that were used in this slide. Thank you.